Let me bring warm greetings from the Dreaming Spars of Oxford. As Abdul Rahman said, we'd be very keen to welcome you to my college in Oxford next September, so I hope to see you all there. I'm going to give a rather general talk following that excellent presentation by Dr. Bamfley, just to give an introduction to the principles of precision medicine. Sir William Osler, who was a distinguished Regius Professor of Medicine in Oxford, was perhaps the founding father of modern medicine. And look at this important quotation that he made. Don't tell me what type of disease the patient has, tell me what type of patient has the disease. And that just tells us about the importance of the interaction between the environment in which we live and the genes that we inherit from mother and father. And clearly, all carcinogenesis is the interplay between these two different areas. I would argue that all of us who are clinicians, all of us, surgical oncologists, radiation oncologists, medical oncologists, already practice personalized medicine. Every time we see a patient, we make individualized treatment decisions which are based on the characteristics of the tumor, the patient, and the treatment that we plan to give. So although we'll concentrate a little on the molecular biology of disease, isn't it true that as practicing physicians already we're looking at personalized medicine? We're graduating the decisions that we made according to performance status, according to age, according to whether we think the patient will tolerate patterns of toxicity. So personalized medicine has been somewhat hijacked by the molecular geneticists, but this is a term I think that can apply to us all. Dr. Bamfley said this more eloquently than me, but these are the principles of precision medicine. And what I'd like to do is to illustrate these with my own field, which is GI cancer, and some of our own molecular assays that we've been developing in Oxford. Prognosis is really important, and I hope to demonstrate that to you. So the right patients, looking for companion diagnostics, Dr. Bamfley's beautiful talk, the right drug for the right tumor type. I think safety is important and drug dose. We need to be better at predicting which patients are going to have life-threatening toxicity so we can use modern genetics to better deliver the right dose. And I'm very interested in susceptibility. One of the things that happens as you become an older cancer doctor, you become a public health doctor. So prevention is better than cure. And I have no doubt that we should be putting more of our effort into early detection and prevention. I do a lot of work in sub-Saharan Africa, and as a young oncologist in Glasgow 30 years ago, when I do clinics in Dar es Salaam in Tanzania, 90% of the patients present with stage 4 cancer. I was doing a clinic there 2 years ago, and 30 years later, 90% of patients present with stage 4 cancer. Whether those patients are treated in Riyadh, Oxford, or New York, it makes no difference. The outcome will be the same. So unless we can come up with better, more effective, simpler, cost-effective means of detecting cancer earlier, that we're not going to make many inroads in the developing world. Again, I think prognosis is important. Much of the work that we're focusing on is predictive markers, putting the drug and the tumor phenotype together. But prognosis is really important, and I'll demonstrate that to you with a little of our own work. So we for the past 20 years really, have been looking at adjuvant trials for colorectal cancer. That's what my trials office and laboratory in Oxford are interested in. And we were the first group to be able to demonstrate this small but important survival benefit for post-operative adjuvant chemotherapy for patients with stage 2 colon cancer. It's a very large study, 3,500 patients, and over the past 20 years, we have randomized about 16,000 patients. This is to Abdul Rahman's point, again, about this region collaborating more to do large substantial trials. The work that I see coming from here represents high quality phase 2, good retrospective studies, but I think you have the intellectual power and the patient power to start doing some definitive randomized trials. And as I say, when we started, there was no practice of adjuvant therapy, and we've now randomized very large numbers of patients to large trials portfolios. Anyway, so here's a quasar study. In 6 months post-operative adjuvant chemotherapy, 4% absolute improvement in survival, which means that we're clearly over-treating the vast majority of patients. We have to treat 100 patients to cure 4. There may be a toxic death rate of 1% and a significant burden of morbidity in 25–30% of patients. So if we knew which patients were at lower or higher risk of relapse, that would give us the possibility of stratifying patients using a prognostic marker to make clinical decisions about should we give adjuvant chemotherapy, yes or no, or should it be more intensive treatment. So patients at low risk of recurrence, I would say, is cured by surgery, no adjuvant chemotherapy. Patients at high risk of recurrence, and therefore the absolute benefits of chemotherapy are higher, that's much easier for us to convince a patient that they should consider that sort of treatment. And the health economics stack up true. So believe me, I'm not going to give you the details of this. It's a different lecture for a different day. We've done a lot of work molecularly characterizing our colorectal tumors. We have a biobank of over 5,000 samples. We have germline DNA. We have DNA from the tumor. So we have a massive amount of information. In Oxford, I should say this, so Oxford is the #1 medical school in the world. Did you know that? So we beat Harvard, we beat Yale. This is fantastic. So we sort of put our elbow in the face of our American colleagues, and clearly we encourage greater collaboration between the Gulf, between this country and the United Kingdom. So that's me sloganizing for the United Kingdom. So we've done a lot of molecular analysis. But the best markers of prognosis that we've got are these very simple ones. Looking at stroma and looking at DNA content. Wasn't that disappointing? You think it would be a fantastically complicated gene signature involving lots of mutations and SNPs and so on, but no. It came out just looking at the tumor microenvironment is as important a determinant of prognosis as mutations in the epithelial tumor. So we need to look at the environment as well. So the more stromal cells are on the tumor, the worse the prognosis. And if we have tumors which have a DNA content which is aneuploid, that's more DNA than normal, this carries a bad prognosis. And when we put these two together, we get very nice separation. We get very nice separation of survival into a group which has got a very low chance of recurrence, the blue line, an intermediate group with the red line, and a high risk group with the black line. What would that mean in my clinical practice? Patients who have a very low risk of recurrence, I'm not going to give them chemotherapy. I'm going to say, alas, the likelihood of being cured by surgery is high. The benefits of chemotherapy are small, no treatment. The patients in the black group, I want to give them intensive chemotherapy, and the group in the middle, that's a decision between you, and possibly consider single agent capecitabine or something of that order. So by using prognostic markers in this way, we can make therapeutic decisions. And in Oxford, the algorithm that we use in our pathology department is to look at microsatellite instability, and Ashok and I will be talking about that in one of the parallel sessions this morning. But we're interested in microsatellite instability. That's a good prognostic group. But for those patients who have T3 tumors, who are mismatch repair proficient tumors, we do our test, and that practically impacts on the advice that we give the patients. What about the right dose? In the United Kingdom now, any patient who dies within 30 days of chemotherapy, their case is presented to the local legal system. So think about that for a moment. So chemotherapy safety has become a very, very high order event in our country that involves the hospital and the government's legal system in investigating why patients die as a result of the side effects of chemotherapy. And therefore, we've been doing some genome-wide association studies. These are large correlative studies linking toxicity to the patient's genes to see if we can come up with a signature that would allow us to find which patients are more at risk of developing serious toxicity. So we've called this is a new science. How do you invite? So we invented a new science called toxnostics. How do you do that? Well, you write a review in Nature, and you have 2 basic scientific publications. And then you put it into Wikipedia. So there you are. So that's how you invite a new science. I invite all of you to do the same. So toxnostics. We use a clinical trial. We have well annotated toxicity. We have lots of blood samples, and the key. Abdul Rahman said it, the key is bioinformatics. It's not the sequencing, but it's how we interpret the sequence data. And that's where we're putting a lot of resources and money in Oxford into bioinformatic understanding. So by doing that experiment, a correlative experiment, we've come up with a test which I'm applying to my patients before I treat them. And if we put somebody into, there are categories of very high risk of death is very high, we avoid fluoropyrimidines. Risk of sudden cardiac event, very high, we would use Tomudex. And then for patients at high risk, we might give them 50% of the dose rather than the full dose. So again, here's an assay that we're using in real time to make proper, positive treatment selection decisions, the right dose of the drug at the right time. Final few slides are on risk and susceptibility. We have a national colorectal cancer screening program in the UK, which is based on fecal occult blood testing, and it saves thousands of lives. So that the benefits of chemotherapy, I can improve survival in high-risk patients by 7 or 8%. The screening work improves survival by 10 to 15%. But the results are dramatic, even for a very inefficient test like fecal occult blood testing. You get earlier stage migration, you get increased cure rate, and you save thousands of lives. And we know that colorectal cancer is becoming more important in the kingdom, and you should be thinking about the introduction of a national screening program here. We're very interested to see, could we look at genetic risk? Could we develop tests that were better than fecal occult blood? And again, we did this is a big experiment. This experiment has taken us 12 years. So we take lots of individuals with colorectal cancer. We have controls who don't have colorectal cancer, and we look for differences in the genetics to see if we can come up with a signature. We've had to study 51,000 individuals to come up with a gene signature. This is a big experiment. But now we think we have a gene signature. These are some of the genes that, these are single nucleotide polymorphisms, again described by Dr. Bamfley. These are some of the SNPs that we discovered, which give you an increased risk of developing colorectal cancer. And for those of you interested in biology, many of them are associated with the TGF-beta supergene family. That's interesting in terms of immunology and in terms of epithelial proliferation. What it means, though, is that we now have a signature that we can apply to normal citizens, normal people, that tells us if they have a 3 to 5-fold increased lifetime risk of developing colorectal cancer. In the UK, the lifetime risk is 1 in 50. Patients who've got these abnormal genes, their lifetime risk is 1 in 10. Now that makes a difference. If I knew I had a 1 in 10 risk of colorectal cancer, I change my lifestyle, I change my diet, exercise, and so on, and I get a regular colonoscopy. And I know that by doing that, I would reduce my chance of dying of colorectal cancer. So we have a genetic test intervention, and we have a practical thing that we can do to offer to individuals who are seen at high risk. Too often, many of these genetic risks tests are of poor quality. The risk ratios are low. The quality of the DNA sequencing is low, and there's nothing practical you can do about it. You can go, I'm going to get dementia. It's nonsense, of course, because the hazard ratios are very small, but there's nothing that you can do to avoid it. With this test, it's a good test, it works. Plus, there's something practical that you can do to make a difference and change it. Where are we heading in personalised medicine? I think the biggest innovations will come around liquid biopsy. Abdul Rahman alluded to this already, and we're improving genomic profiling all the time. The idea behind liquid biopsy is that you can take a biopsy of the whole tumour. We know that tumours become heterogeneous as they grow, as they mutate and change, and in order to be able to be certain that you're detecting a RAS mutation or an ALK fusion, you should really be taking multiple biopsies because there are different microenvironments within the tumour. The liquid biopsy overcomes that. Innovations in genomic profiling technology, you can see that there are two different ways in which we can go. High throughput genotyping multiplex screens, targeting to mutations and regions of interest. So taking all the information that Dr. Bamfley told us about, can we put that into a single multiplex test? Rather than Abdul Rahman having to send tissue to 6 different laboratories to get the answer, can we have multiplex tests that will allow you to take a lung cancer biopsy for one test that gives you the information that you need? Another extreme, if we look at next generation and exome sequencing, that's the search for novel biomarkers, and people like the Broad Institute, the Crick, etc. Some of these very large genomics institutes in the leading centres should be doing that work in terms of discovering new biomarkers. This is the last slide. It's a slightly weird one, but I put it in because from the outside, this is a time of change within the kingdom. You're looking to broaden and change your economy. I know that you're looking to move to a knowledge-based economy. And this is just to show that, simple scientists, people like myself, in Oxford, we're encouraged to develop intellectual property and spin out companies. So all that science that we've been working on, that we publish in fancy journals, we can take that, we can produce patents, and then the university spins it out into small biotech companies. And therefore, if we can do that in Oxford, we have a rather privileged position. These are the sorts of patterns that you might and should be able to follow with resource, with intelligence, with drive and ambition in Saudi Arabia too. Thanks very much.